इवनिंग। यस। अच्छा, लिंक आपके पास नहीं है? मैं अभी भेजता हूँ, आपको तुरंत भेजता हूँ मैं। हेलो अनंत।
सर गुड इवनिंग।
हाँ जी, सुशांत को आप लोगों ने लिंक नहीं भेजा है ना?
सर 2 बार मेल किया उनको मैंने, आज सुबह में भी किया हुआ और 3 दिन पहले भी मेल किया है।
व्हाट्सअप कर दीजिए ना।
ठीक ठीक।
गुड इवनिंग एवरीवन। Dr. Sushant will soon be joining, I think within a few seconds.
सर उनको व्हाट्सएप कर दिए हैं सर।
गुड इवनिंग डॉक्टर सिन्हा सर। Sir, you are muted.
So let me again welcome Dr. Sushant Srivastava. He is a chairman of adult cardiac surgery and heart-lung transplantation at Artemis Hospital, Gurugram. And if you see his bio data, it is amazing. And he's a man who has stood from a place like Muzaffarpur, SK Medical College, Muzaffarpur, to All India Shoot, and his boundaries are limitless, I would say. his his publication, his work is phenomenal. So I was just trying to have a chat with him in the afternoon. He said, no, valve, covering the whole valve issue in one go would be very difficult. So why not cover only aortic valve? So he'll be covering only aortic valve today. And as we know that, as the rheumatic heart disease has gone down, the degenerative diseases have gone up. So we have more of degenerative aortic valve disease now, apart from the congenital like bicuspid and all those things. So may I request Dr. Sushant Srivastava to enlighten us and our students with his knowledge and expertise. Thank you, sir. Welcome.
Thank you, sir. Thank you. Um, Thank you very much for that kind introduction. As Dr. Sinha said, I had initially planned to cover valvular heart disease and its relevance to the general practitioner in 2 sessions. But when I got down to it, I found that this topic was much too vast for 2 sessions of an hour each. And that speaks of my inexperience in foreseeing what can be fitted into a short space of time. Despite having done thousands of valves, I did not realize that the information could not be squeezed into 2 short sessions. So I made amends since, and I will confine myself today to aortic valve disease. I've tried to tailor this presentation to this specific audience, and it's a privilege to be with you. Thank you very much for the opportunity. So may I begin? Now, the purpose of any such discussion is fourfold: to suspect, recognize aortic valve disease based on the history and clinical examination, to confirm the diagnosis with appropriate investigations, to manage and advise surgery at the correct stage, and that's of paramount importance. Delayed surgery or too early surgery is not of much value. And then after surgery, after successful surgery, when the patient returns to the physician to follow him up and manage the post-intervention or the post-surgical period appropriately. So we are all familiar with the global burden of valvular heart disease. Valvular heart disease afflicts millions of people worldwide. And despite advances in medicine and economic progress, rheumatic heart disease is still the commonest form of valvular heart disease. The estimate is 41 million people. A close second and third are calcific mitral and aortic valve disease, and the numbers are 21 and 9 million respectively. Now, post-mortem studies suggest that all these numbers are underestimates, which means the actual burden of valvular heart disease is larger. Now, there are other surprising facts about valvular heart disease. The incidence of valvular heart disease is increasing, and perhaps This is just looking at the numbers of patients afflicted with valvular heart disease. And since the global population is growing, the incidence of valvular heart disease is growing too. This is also due to the rapidly growing populations of developing countries. And for that reason, there's a second thing that's happening and is worthy of note, is the fact that rheumatic heart disease is still the most prevalent form of valvular heart disease. Now, calcific aortic valve disease is increasing due to increased longevity, due to an aging population. Endocarditis, surprisingly, is increasing too. One would expect endocarditis to come down because we have better medical facilities, but two reasons uh, for increasing endocarditis. One is aging and increased intervention. Intervention often leads to implants and surgery, and these procedures cause bacteremia, and in patients with vulnerable valves, the bacteria can seed on the valves and cause endocarditis. So endocarditis is increasing too because of implant endocarditis or device endocarditis. The population of patients who have undergone intervention or surgery is increasing, and this is a special subset with special problems, and they need to be managed separately. Now, these are the heart valves. We are all familiar with the anatomy, with the gross anatomy of the heart. Two valves on the right and two valves on the left. The tricuspid valve guards the inlet of the right ventricle. The outflow is guarded by the pulmonary valve into the pulmonary artery. The inflow of the left ventricle is guarded by the mitral valve, and the outflow into the aorta is guarded by the aortic valve. And on the right, you see a diseased, calcified, stenotic aortic valve. Now, there are two or three things that we need to know before we embark on a discussion of aortic valve disease or any valvular disease. We need to understand that there are conditions which might, to the untrained individual, appear to be valvular heart disease, but they are in reality not due to heart disease, or they are not of clinical significance. And these conditions are mild physiological regurgitation. If we do echocardiography in the normal population, many people, a significant proportion, will have mild mitral regurgitation or tricuspid regurgitation. In the elderly population, many people will have early valve calcification. But both these conditions, perhaps one is physiological, the other is a consequence of aging. They are non-progressive and do not have major prognostic implications. So let's begin the discussion of aortic stenosis. I begin with the causes of aortic stenosis. This is by no means an exhaustive list, but these are the important causes of aortic stenosis. Rheumatic heart disease tops the chart. There's degenerative valve disease in a tri-leaflet valve. There's progressive stenosis of a bicuspid aortic valve. The bicuspid aortic valve is an abnormal congenital valve which functions normally at birth and in childhood in most patients, but begins to deteriorate in early adulthood, leading either to aortic stenosis or to aortic regurgitation. And then in addition to aortic stenosis, there can be a narrowing of the left ventricular outflow tract or subaortic stenosis, or a narrowing of the aorta distal to the valve, which is known as supraaortic stenosis. What's the natural history of aortic stenosis? Aortic stenosis is a gradually progressive disease and increases in severity over many years. The LV, the left ventricle, compensates by a concentric hypertrophy. This serves to preserve the LV systolic function. But ultimately, in the face of continued obstruction and increased workload, the LV function begins to decline and the LV dilates. It can still at this stage recover after valve replacement surgery or removal of the obstruction. Now, it is very important to realize that even in patients with aortic stenosis who have LV dysfunction, the LV can recover, and therefore surgery must be advised, or at least surgical opinion or an opinion for TAVR must be taken, because if the obstruction is removed, there is a good chance that the LV will recover. Now, if that stage passes to, there occurs irreversible myocardial fibrosis, and this is at a very late stage, and then the chances of the LV recovering its function is very small. Now, that's aortic stenosis, and on the right-hand side, you see a hypertrophied LV as a result of aortic stenosis. What are the symptoms of aortic stenosis? Aortic stenosis remains asymptomatic for many years and may be incidentally discovered during a visit to the doctor. Later on, these symptoms set in. The first one is chest pain. The second one is fatigue. There can be fainting or syncope, and there can be shortness of breath. Based on the symptoms, the symptomatic status of the patient, Lombard and Selzer have proposed a very useful classification. There are patients who are asymptomatic. There are patients in the second group who have angina or syncope. These are pre-failure patients. Patients who have angina or syncope usually do not have heart failure. And then there are patients who have dyspnea. These patients have either heart failure is beginning to set in, or they have frank heart failure. So this is a very useful clinical classification which helps us categorize patients. Now, the clinical features are well known. Most of us have studied the clinical features well in college. The pulse is slow rise. It's known as the pulsus parvus et tardus. It is best appreciated. This character of the pulse is best appreciated in the carotids. The pulse is slow rise because there is obstruction of the left ventricular outflow. As a result, the stroke volume is reduced and the pulse pressure is narrow. Now, the apical cardiac impulse is not usually displaced unless heart failure has set in. The second heart sound is often single because the aortic valve is very often calcified and does not produce a sound, does not close well, and does not produce a sound on closure. An S4 may be palpable due to a vigorous atrial contraction. The hypertrophied ventricle is non-compliant, and therefore the atrium has to work hard to push blood into it. This indicates LV hypertrophy and severe aortic stenosis. So in a young patient, an S4, a palpable S4 indicates severe aortic stenosis and LV hypertrophy. Auscultation reveals a crescendo-decrescendo systolic murmur. This is best heard at the upper right sternal border or in the aortic area, and it radiates to the carotids. Caution must be exercised in the elderly. Many elderly patients will present with aortic stenosis. A distinction must be made between the murmur of aortic stenosis and a carotid bruit from carotid atherosclerosis. Carotid atherosclerosis and carotid artery stenosis as a result is becoming increasingly common. We encounter it very frequently in our clinical practice. In young patients with bicuspid aortic valves, an ejection click may be heard, and that's the picture of the murmur, a crescendo-decrescendo murmur. The ECG shows left ventricular hypertrophy. There are tall R waves in V5 and V6, and not in this ECG, but there are often deep S waves in V1 and V2. There's the strain pattern, which means ST depression and T wave inversion in one AVL and the lateral leads. And because of LV hypertrophy, the QRS duration may be prolonged. Now, the investigation of choice is echocardiography. It establishes the diagnosis. It demonstrates the morphology of the valve, whether it is bicuspid or tricuspid. whether it is calcified or not, and these findings have implications on the treatment. It measures the valve area and therefore classifies the severity of aortic stenosis. And also it measures the gradient. And finally, last but not the least, it measures left ventricular function. So that has implications for treatment as well. Now, this is the classification of the severity of aortic stenosis, the two most important parameters on which the severity of aortic stenosis is graded are the mean gradient and the aortic valve area. The mean gradient, if the mean gradient is less than 20, it is mild. If it is 20 to 40, it is moderate. And if it is more than 40, it is severe. The aortic valve area more than 1.5 centimeters square is mild. 1 to 1.5 is moderate, and less than 1 centimeter square is severe. There's a parameter called the indexed aortic valve area, and it is of use in surgery and in deciding the severity in some patients. An aortic valve area of 1 to 1.5 centimeters square may be moderate in a patient who weighs 70 kilos. But if the patient has a large body surface area and is heavy, maybe if he's 90 or 100 kilos, then that stenosis is no longer moderate. And that's when the indexed aortic valve area becomes useful. If the aortic valve area is matched against the body surface area for a patient with large body surface area, that aortic valve area may be severe. So it's of use in those special circumstances and also in surgery in choosing the size of the valve. So this is the echo of of a patient with aortic stenosis. You can see the valve is thickened, doesn't open well, and the opening is narrow. Across the valve, there's a turbulence on the other side in color flow. So the echo gives very valuable information. You can see that the valve does not open well. It moves sluggishly and does not open well. And it's thickened. This particular view is also of use in measuring the size of the aortic annulus, which is useful in planning surgery. Now, what are the special things to look for in the echo? In a bicuspid aortic valve, the diameter of the ascending aorta must be measured, as 25% of patients with a bicuspid aortic valve, which is stenotic, can have ascending aortic aneurysms. These patients have an aortitis, which is present in 25% of patients with bicuspid aortic valves, and the aorta dilates and becomes aneurysmal. Now, if the ascending aorta is found to be dilated on echocardiography, the patient must have a CT angiogram to determine the extent and the size of the aneurysmal aorta so that that can be factored in to the treatment plan. Now, cardiac catheterization is nearly never done, never required in patients with aortic stenosis. But if the patient is older than 40 years, then a coronary angiogram is routinely done for coexisting coronary artery disease. So when the patient has aortic valve replacement surgery, he can also have surgery for coronary artery disease if it is present, a bypass graft or 2 or 3 bypass grafts, as the case may be. Patients who may not be 40 years old but have significant angina should be interrogated with coronary angiogram. If there's coronary artery disease, it should be treated in the same sitting as valve surgery. There's a phenomenon called sudden death which occurs in aortic stenosis. And for this reason, one should be very careful in following up patients with aortic stenosis, and they must be referred for intervention or treatment at the right stage. It's been found that it occurs in less than 1% patients who are asymptomatic, but in up to 9.2% patients who are symptomatic. So if a patient with severe aortic stenosis is symptomatic, he should be urgently referred for surgery or referred for early surgery so that this catastrophe does not happen. Now, what is the cause of sudden death in patients with aortic stenosis? It is usually a malignant ventricular arrhythmia. It's ventricular tachycardia or fibrillation or asystole. Now, when ventricular tachycardia or fibrillation occurs in a tightly narrowed aortic valve, the ventricle dilates quickly. And once it dilates, it's very hard to resuscitate it and get it back into sinus rhythm. There's also myocardial ischemia, and this is due to two reasons. One, the left ventricular myocardium is hypertrophic, and therefore its metabolic demand is high. It has to work hard against a narrowed aortic valve. So it is ischemic, and the metabolic demand is high. In addition, the reduced stroke volume leads to less flow into the coronary arteries, and therefore there are two reasons for which myocardial ischemia can occur. And when an arrhythmia occurs, or when the heart fails, the LV myocardium, which is already ischemic, gives up, and this catastrophic phenomenon can occur. There's also something known as the Basal-Jarisch reflex. It is an abnormal LV baroreceptor stimulation leading to severe hypotension, but I'm not sure how much it contributes to the phenomenon of sudden death. What are the indications for surgery? There's no doubt that symptomatic patients with documented severe aortic stenosis should be subjected to either surgery or TAVR. Asymptomatic patients with severe aortic stenosis and LV dysfunction should also have surgery, and this is as much to treat the aortic stenosis as to preserve the LV function, which will have a long-term impact on the quality of life and survival of the patient. Moderate aortic stenosis with other heart valve disease meriting open heart surgery should also be treated with surgery. For example, if a patient has mitral valve disease or some other reason for undergoing open heart or bypass surgery and has moderate aortic stenosis, the valve should probably be changed in the same sitting. If it is not, then the patient will come back for surgery within a year or a couple of years and will have a second open heart surgery, which is not fair to him. Now, it's important to realize that severe mitral valve disease leads to an underestimation of the severity of aortic valve disease. So when there is severe mitral valve disease, either stenosis or regurgitation, and there is a moderate aortic stenosis, it is probably in reality severe, and it should be treated as such. What do we do for patients who are asymptomatic and who have severe aortic stenosis and normal left ventricular function? Now, these patients might have vague symptoms. Often these patients are actually symptomatic, but they learn to limit their physical activity to avoid symptoms. So the need is to take a careful history and subject them to stress testing under carefully controlled conditions. Now, stress testing might precipitate symptoms, but it should only be done where resuscitation facilities are available. There's another group of patients who have LV dysfunction, and though the aortic stenosis seems to be severe, the gradient may not indicate severe AS. These patients can again be subjected to a careful dobutamine stress echo. This test may reveal the true severity of the aortic stenosis by increasing the gradient. So this is the algorithm of management of aortic stenosis. I've tried to break it up before presenting this chart to you because charts are confusing. So if there's severe aortic stenosis and the aortic valve area is less than 1 centimeter square, if the patient is undergoing other heart surgery, the valve should be replaced. If the patient is symptomatic, the valve should be replaced. If symptoms are not clearly present, if they are equivocal, the patient should be subjected to exercise testing if there are symptoms, or if the exercise test leads to hypotension, the valve should be changed. Now, if the exercise test is normal, then the LV ejection fraction should be looked at, and we've discussed this already. If the LV ejection fraction is reduced or less than 50%, again, this is an indication for aortic valve replacement. But if the LV ejection fraction is normal, there's severe valve calcification or rapid progression of stenosis in serial echoes, then the patient should be advised surgery. But if none of these are present, then the patient should be clinically followed up and annual echocardiography should be done. As and when the patient meets the criteria for having surgery, he should have surgery. Let's now discuss aortic regurgitation. Aortic regurgitation can occur for two reasons: abnormalities of the cusps and abnormalities of the supporting structures in the aortic root or annulus. Now, cusp abnormalities are most often caused by rheumatic heart disease, bicuspid, unicuspid, or quadricuspid valves. These are all congenitally abnormal valves. Rupture of a congenitally fenestrated valve and some connective tissue disorders will affect both the root and the cusp, such as Marfan syndrome. Now, these are conditions which affect the aortic annulus or the aortic root, namely Marfan syndrome, the Ehlers-Danlos syndrome. In bicuspid aortic valves, 25% of patients have aortitis. This leads to a dilatation of the ascending aorta and sometimes to a dilatation of the aortic annulus as well. The deformed valve here contributes to the aortic regurgitation too. There's aortitis associated with ankylosing spondylitis. There's syphilitic aortitis. Again, by no means is this an exhaustive list, but these are some of the important causes of annular dilatation leading to aortic regurgitation. And this is what the dilated root looks like. This is a CT angiogram in a patient with chronic dissecting aneurysm of the aorta. This patient had severe aortic regurgitation and a hugely dilated aortic root and an aneurysmal ascending aorta. So he underwent a valve replacement, a conduit replacement of the ascending aorta, and half of the arch or a hemiarch. Now, what's the pathology in aortic regurgitation? There is excessive preload. The ventricle fills soon after ejecting because the valve is not competent. Much of the ejected blood will flow back into the ventricle. That dilates the ventricle. There's increased afterload too because the high end diastolic volume forces the ventricle to contract forcefully. This leads to high systolic pressure, and both together increase the LV wall stress. Now, to compensate for these conditions, the LV dilates and undergoes eccentric hypertrophy, and the LV function is maintained. These are compensatory mechanisms and to maintain LV function. But finally, the LV reserve runs out, it is exhausted, and LV dysfunction sets in. Now, this is a very important stage. It must be anticipated and preempted. So, what are the findings of aortic, the physical findings in aortic regurgitation? Aortic regurgitation leads to a set of very